You will notice in this section that we skipped over some of the stuff in Chapter 18. There's some really nice, complicated information about spinal cord motor coordination and control of pelvic organs, and we are not going to talk about that in this class at all, so you will not be responsible for that information. We are going to go right now into talking about spinal tract dysfunction, spinal cord dysfunction. So we're going to talk about some spinal region syndromes, some of which are caused by traumatic spinal cord injury, but we're going to have a separate section talking specifically about traumatic spinal cord injury. So for the learning objectives for this section, I want you to be able to describe the 5 syndromes that we talk about in this lecture, their etiology, and which body functions are lost and or spared in each. So when you think about things being lost and things being spared, basically anything that's not lost is spared. Sometimes you lose sensory, but you spare motor. Sometimes you lose motor, but you spare sensory. And get that idea. So there are, in one section in the chapter, there are red flags for spinal cord injuries, and red flags specifically, I want you to be able to list the red flags for cauda equina lesion, and we'll talk about that. It's one of the spinal syndromes. So when we have segmental and tract lesions in the spinal cord, so a segmental lesion affects an individual segment. Vertical tract affects the entire vertical tract. So a segmental lesion affects the function of a single spinal cord segment. Segmental lesions interfere with neural function only at the level of the lesion. Okay? Vertical tract function, the vertical tract conveys ascending and descending information. So lesions interrupting vertical tracts result in a loss of the function below the level of the lesion. So that's an important way of differentiating the spinal region from peripheral region lesions and segmental from vertical lesions. So in a couple of weeks, we're going to have a discussion similar to what we did in pathology, sort of the name the disorder dysfunction, and we are going to have for neurological disorders. So one of the things that I want you to specify when you're doing it is I want you to specify the symptoms so we can tell if it's a segmental or vertical tract function. And in the description for the assignment, I will specify how you do that. So signs of segmental dysfunction. A lesion affecting a single level of the spinal cord causes segmental signs at that level. So segmental signs include abnormal or lost sensation in a dermatomal distribution or motor neuron signs in a myotomal distribution. Remember, that's the either the skin or the muscle that's innervated by a single nerve root level. A lesion of the ventral horn, ventral root, or spinal nerve interferes with motor neuron function. A lesion of the dorsal horn interferes with sensation. Okay. So in this picture, they have it's a C5 lesion. In the book, they show that little black line to indicate that's where the lesion is. And so because the lesion is affecting both the dorsal and the ventral, it's affecting the whole spinal nerve. The muscles innervated by C5 and C6 are combined with loss of C5 sensory information. Okay. So signs of vertical tract dysfunction. The lesions interrupting vertical tracts result in loss of communication to and or from the spinal levels below the lesion. So you get motor information gets interrupted. It can't reach the levels below the lesion, and sensory information can't get from the levels below the lesion up to the central nervous system. So ascending tract signs include problems with the regulation of blood pressure, sweating, and bladder and bowel control, and those are all autonomic things. Descending tract signs include paralysis, spasticity, and muscle hypertonia. If the lateral corticospinal tract is interrupted, you may have Babinski's sign present. All signs of damage to vertical tracts occur below the level of the lesion. So in the previous slide, we had that one level affected, that C5 level. In this one, we have everything below the C5 level is affected, and that is a sign of vertical tract dysfunction. So spinal region lesions may cause both segmental and tract signs depending on where the lesion is. So a lesion at the C5 level on the right that involves the right dorsal quadrant of the spinal cord. So in the dorsal quadrant, remember, we have the dorsal horn, which carries sensory information, and the dorsal column, which carries sensory information. So a lesion at the C5 level on the right involving the dorsal quadrant of the spinal cord prevents light touch and conscious proprioception from the right side of the body below the level of the lesion, below C5. And prevents it from reaching the brain and the lateral corticospinal tract information from reaching the right side of the body below C5. And sensory information from the C5 dermatome and myotome would be lost. So, in order to differentiate spinal region from peripheral region lesions, peripheral region lesions produce deficits in the distribution of a peripheral nerve. So, peripheral nerve lesions cause altered or lost sensation in a peripheral nerve distribution. Decrease or loss of muscle power in a peripheral nerve distribution. No vertical tract signs. And decreased or lost phasic stretch reflex. Spinal region segmental signs occur when nerve roots or spinal nerves are compromised. And segmental signs include altered or lost sensations in a dermatome, decreased or lost muscle power in a myotome, and decreased or lost phasic stretch reflex. So spinal region, so very similar, the peripheral region lesions and the segmental spinal regions are pretty similar, right? The vertical tract signs, on the other hand, include altered or lost sensation below the level of the lesion, so not just in one myotome or dermatome. Altered or lost descending control of blood pressure, pelvic viscera, and thermoregulation. So those are those autonomic parts of it. And so that is a big sign of vertical tract lesion. Motor tract signs include decrease or loss of muscle power, spasticity, muscle hypertonia, and if the lateral corticospinal tract is involved, positive Babinski sign and clonus. So they're distinct from segmental or peripheral signs because of their pattern of loss. So a syndrome is a collection of signs and symptoms that do not indicate a specific cause. So they classify it by the signs and symptoms rather than being classified by the cause. So this is a little diagram from the book that shows 4 spinal region syndromes, and we'll talk about sort of each one of those. But because of the layout of the spinal cord that we looked at in the last lecture, the part of the spinal cord that's affected is going to affect your symptoms. Hopefully that makes sense. So syndromes are often resulting from tumors or trauma. So usually a spinal cord syndrome is something that isn't a complete severance of the spinal cord. So a traumatic spinal cord injury that causes complete severance of the spinal cord isn't one of these syndromes. Traumatic spinal cord injuries are often caused by trauma, but syndromes can be caused by other things like tumors or more specific type of injuries. So anterior cord syndrome interferes with pain and temperature sensation and motor control. And that makes sense, right? So when you look at this picture, in the top left-hand quadrant, it's that anterior part. The thing that's affected in the anterior part of the spinal cord is the motor tracts and the, there we go, got on the wrong thing. The motor tracts and the pain and temperature sensation. Central cord syndrome in a small lesion, and usually central cord syndrome tends to happen in the cervical cord. In a small lesion, you get loss of pain and temperature at the level of the lesion. In a large lesion, upper limb motor function is impaired. Since it happens in the cervical, it's upper limb. Brown-Séquard syndrome is a hemisection of the cord usually, and below the level of the lesion, you lose voluntary motor control, conscious proprioception, and light touch ipsilaterally, so on the same side as the lesion, but you lose pain and temperature sensation contralaterally on the opposite side of the lesion. And that has to do with where the tracts cross over. We know that the voluntary motor control, conscious proprioception, and light touch cross over in the medulla. So if you have a lesion that's lower than the medulla, you're going to lose those things on the same side as the lesion. The pain and temperature sensations actually cross over at the spinal cord level, and so you're going to lose those sensations contralaterally. Okay, I hope that makes sense. So I want you to be able to, if I gave you some losses, like if I said loss of voluntary motor control, conscious proprioception, and light touch ipsilaterally below the level of the lesion, I want you to know that that is involved with Brown-Séquard syndrome. Hopefully that makes sense. We'll talk about it. Cauda equina syndrome is the fourth one when I mentioned 5 in the learning objectives. Cauda equina syndrome causes sensory impairment and flaccid paresis or paralysis of lower limb muscles, bladder, and bowels. A lot of times when people come in with cauda equina, they come in with either unilateral or bilateral sciatica, and we'll talk more about the red flags for this, and with reports of bowel and bladder function changes. Tethered cord syndrome causes low back and lower limb pain, difficulty walking, excessive lordosis, scoliosis, and problems with bowel or bladder control and foot deformities. So tethered cord syndrome is a developmental issue, and so the symptoms tend to come on throughout growth as you get more and more tension on the spinal cord. So the effects of the spinal region lesions on bladder, bowel, and sexual function depend on the level of cord damage. The effect of spinal cord lesions on bowel control and sexual organ function is similar to the effect of spinal cord injury on bladder function, and we'll talk about that in the next section of the lecture. Sexual dysfunction is a significant issue for many people following spinal cord injuries.